All right, Chapter 5, End of Life Care. Not that we want to talk about this, but it does happen, so we need to be prepared in case we are on a floor that has a demise. End of life care, very similar to adult end of life care, like hospice. There's hospice for children as well. There's Make a Wish Foundation, so you know that they're able to make a wish and do one last trip with their family. So there are some good parts to this as well. So it's a lot of supporting the family, a lot of supporting the child to have a good ending with quality of care. So again, disclosure statement, I don't own this material under fair use. I'm providing lecture content only for my nursing students using this material. And all content is for nursing student purposes and not for providing medical advice. So this chapter, we're going to be talking about understanding causes of infant and pediatric death, because if we know why they die, we can prevent that potentially. Some we can and some we can't. Describing appropriate communication with the patient and family in end-of-life care, and understanding and describing the communication that happens at the end of life with the family and the multidisciplinary team, the roles of the patient, family, DIDAD, and the culturally competent care. Describe and define hospice care, roles of the nurse and the interdisciplinary team, the assessment and the treatment of pain in hospice, and explaining the role of spiritual and cultural care will have within the end of life care. Define the stages of grief, and you should know that from Kubler-Ross, even in med-surg, we talk about that, so that shouldn't be new. Understanding and describing the role of nursing education in end-of-life care. Define and compare the stages of grief, and understand and describe the role of nursing education at the end of life, and withdrawal of care. Define and describe the role of the nurse in infant and pediatric end-of-life care, and describe organ donation and procurement. Define and describe legal aspects of end-of-life care. So let's get started on here. So death is defined as the end of sustainable life, and death is the end of a short life caused by a terminal diagnosis or disease. So typically there's a terminal diagnosis either from trauma or physiologic causes. So some of the categorizations that we have is trauma caused by outside forces, so such as a car accident or a drowning. Car accidents do happen, and we know that children should be put in a car seat, but they are not always adequately restrained in a car. So those things can happen. We provide education and prevention by getting the car seat in the car correctly. But at the end of the day, it's the parents decide to use or not use restraints in the car. Non-accidental, such as intentional self-injury or abuse. Physiologic, caused by forces within the body, such as cancer. A congenital defect, such as Edwards syndrome. So sometimes there's cardiac anomalies as well that will be a terminal diagnosis. The goal altogether is a peaceful death rather than the continuation of a healthy life. So it is a complete change in thought process when we go into end-of-life care with an infant, especially. Unfortunately, there's a lot of life left in that individual. And the goal of our whole nursing care is just to have a peaceful death for that child or that infant. So just to think about some assessments, some causes of pediatric death that are in your book. Mortality from 1 to 4 is 23.3%. So there's 3,000 deaths in 2019. So you can see the numbers. The leading cause of death in 1 to 4 is accidents, congenital malformations, deformations, or chromosomal anomalies, and cancer. 5 to 9 is accidents, unintentional injuries, cancer, congenital malformations, deformations, or chromosomal abnormalities. And then in the 10 to 14, obviously, with more being out in public and being out, there's more accidents and unintentional injuries, intentional self harm, suicide, and cancer. Unfortunately, this age group is becoming more and more a high risk of suicide in the United States. Um, so one of the biggest things in children is sudden infant death syndrome, and that usually comes from the baby in a back sleeping position is more apt to not provide an opportunity for sudden infant death. So that's why we always say back to sleep, back to sleep, back to sleep. So you can see on the picture in your book that putting the baby face down, if he vomits, he may aspirate that vomit and die of asphyxiation. So there's a lot of things that we talk about with safe sleep environments, and you can see it here in your book. It can be even a cardboard box. It does not have to be a crib. It can be a drawer out of a dresser. It can be anything. So we'll talk at nauseam about safe sleep practices because that's one of my favorite things to do with the Native American population up in Montana. I was one of the trainers that had to talk about that. So we'll do that in lab and in class. So communication with the dying patient, assessments, just like an adult, assessments kind of go by the wayside. We do what we need to do, and there's a patient-centered, family-centered care in the end of life. So we're letting the parents do as much as they can still if they want to. And then communication during that time, just determining how the unit functions, how the family functions, develop their cognitive level, their overall understanding of the prognosis of the patient, and then legally who receives information about the baby or the family member. Family centered, so culturally appropriate. We want to make sure that they have what they need at the bedside culturally to provide good care. Developmentally appropriate, consider the developmental levels of siblings and having them present or not present during the end of life. Compassionate, treat the family and patient with kindness, be informative, and be honest. That's the biggest things. You really want to be an advocate for this patient and their last few days. So, a little bit about palliative care and hospice care. Palliative care is earlier on than hospice care. Hospice, you know, is 6 months or less of life left. Then we can put them in hospice care. Palliative care is symptom management, so that may start right away when we find out that they are nearing the end of life. It's a multidisciplinary family-centered approach where the baby is going to be at home or in a center or in the hospital with hospice care provided. The goal of that is pediatric pain care, so there's a whole different palliative care approach for the pediatric patient, and that involves a lot of team members. The goal is that once they receive the terminal diagnosis, that we focus on compassionate care, focused on their comfort, and with as few invasive devices and procedures as possible. It could be in a hospital, it could be at home, it could be with visiting nurses and care aides. So it just depends what the family wants that to look like, and culturally and religiously as well, opening that up to whatever they need to do in those last moments. You want to assess the child's view of death on a developmental level. So, knowing the developmental level of the child, you can figure out if they understand death is real or if death is imaginary. So, if they think like in the cartoons, they're going to bounce back up the next day and keep going, like Bugs Bunny and Roadrunner, that's not, you have to deal with the child's developmental level and the sibling's developmental level, making sure that they understand so they can do final preparations as well. It's a potentially stressful environment if not everybody is on the same page. Desired food choices, diet, pain medication, age appropriate care, Pain control. So lots of different pain. We can offer them different pain medications. In the nursing interactions, they still want to be using our NIPS or our FLAC or our FACES scale and providing good pain medication during the end of life. But depending on the development of the child, might have a different view on death. So infants obviously fear anxiety over separation. 3 to 5 is magical thinker in the formation of peer relationships and gender identification. So they might have an idea that death happens to someone else. They may or may not have ever had somebody die in their family at this point. So death is not a permanent state, and death is reversible in that age group of 3 to 5. When you get into the 6 to 12 years, that's when the enthusiasm for learning and work, building relationships, and self-esteem. So that's where they know that death is final, it's universal, everyone's going to die eventually. Death is recognized as personal and real. So they may want to leave things behind for their family members. In the adolescent, they understand death in a logical manner, similar to the adult understanding, and they realize that everyone will die eventually. You will see the Kubler-Ross stages in your book. So Kubler-Ross is one of the 4 known names in this. Well, so typically we look at this as the stage of grief on the family members, but she came back out and said it's actually not the family members she was talking about when she made this theory. She was actually talking about the patient. So if you think about it, it could be both, and it could also be the family members and the siblings going through this. So the Kubler-Ross stages are denial, anger, bargaining, depression, and acceptance. And you see that in your book. Denial is the unwillingness to accept the diagnosis, the lack of trust in the medical staff. They're in denial. They're trying to get a second opinion. They don't want to believe it. Anger comes towards staff and family members, verbal arguments, confrontation. And then bargaining is kind of like promises of future behavior that will prevent death of the child, reliance on a higher power to prevent death. So they're trying to bargain with God. Take me, not them, kind of thing. And then depression will be crying, withdrawal from family, loss of appetite. And you'll be able to see this throughout your nursing career. And then finally, acceptance, where there's statements of understanding, a positive outlook, and a discussion on the future. Every individual is going to be different, and this can lead to a lot of divorce in families because mom will grieve and dad won't, or dad will and mom is not. So you never know. Grief is very individual, and there's no timeline on it. Unfortunately, in the US, we tend to feel like 3 days is enough and get back to work. That is not enough for anyone. So you will see different grieving on different family members. Which of the following stages is defined correctly? Bargaining to receive or agree what's coming to event? No. Refusal to believe that a child is dead or dying? Depression? No. Anger, an attempt to create change in the situation through agreement for services exchanged. Anticipatory grief. The family of the patient with a terminal diagnosis prepares for death prior to the dying process. So I would go with D. The anticipatory grief occurs before other stages. So when they're finally anticipatory, they're talking about the future and what we're going to do. Okay. So patient education at the end of life, explaining the cause for the terminal diagnosis and the disease that will cause death. They really want an explanation. More than anything, they just want to know why. Why did this happen to my child? Explanation of the current medical interventions and the dying process. So just like in adults, we tell them what to expect, when, how, where, what will we see, what would we expect, to get them prepared for that process. So you remember all of those things from med surg. You're talking about modeling of skin, the Cheyne-Stokes breathing, the gasping for breath, the death rattle. So those things will be the same in the child. We may have to give morphine and pain medicine. We may have to give atropine for drying up those secretions. So that will be the same um, in those situations. What you want to do is make sure that you know what the code status of the child is, because if there's still a full code, we really need to talk about that to the family and go to the ethics committee and really have a firm understanding that we're not going to try to save life at the end of life. Okay. So having these things in writing ready before the withdrawal of care. What you don't want is he said, she said at the end of life, and withdrawing care that involves turning off the monitor, disconnecting the invasive lines, and creating a peaceful, private environment for the family. You don't want any misunderstandings during that. If the family wants to be involved in the code situation, we certainly do. So if they were to come in the ER in a code, we would allow them to be present because they do have the right. We also know that through education and research that they're less apt to sue us later when they have seen that we have tried to do everything for that child, especially in a car accident situation or a trauma situation, drowning situation. So there are patient and family education that we must provide, but keeping things positive. They know that everything was done. The negative aspect is when the family sees the child in the worst case situation. So they may attempt to be at the bedside. It is okay for them to be in the environment of resuscitation. It actually helps us in the end not to be sued. And what can we do? What we can do is give them as much role in saying goodbye, family involvement, religious, spiritual ceremonies, following hospital protocols. This is especially important with infants. So if they're less than 20 weeks, they usually get buried in a communal plot, especially if it's a Catholic hospital. Otherwise, if they're more than 20 weeks, then we go ahead and have the family prepare a burial with a funeral home. So typically before 20 weeks, they're considered products of conception, just legally. Not saying any one way or another about it. It's just we don't have to provide a funeral for anyone less than 20 weeks. We do have to if they're more than 20 weeks. Proper documentation, you just want to make sure everything is kosher and properly documented about the end of life and the cessation of breath and respirations. So some of that family involvement might look a lot like handprints, footprints, and photos being taken, a lock of hair being secured in a little plastic baggie for them. Pictures are very common at the end of life, and we actually have an organization called Now I Lay Me Down to Sleep that comes in and does the photos so that they're actually very good quality photos of the last moments of life. If the baby has already passed away, we'll still do those pictures. We have ways of wrapping the baby and providing cotton in the hat for different situations with anencephaly, and we'll talk about that later on. But when the baby dies, we definitely follow our hospital protocols. There is no hurry in getting this body out of the hospital and down to the morgue. It's very different than the adult world where we need the bed kind of thing. So this, we're giving them their last few minutes with their loved one and truly giving them as much time as they need, because unfortunately you cannot bring those moments back, and those are the moments the mom and dad and the family will remember for the rest of their life. So we definitely want to give them that time. Which of the following is true about the family presence during a code situation? Family should never be involved. No. Family presence can be positive since the family knows everything was done. Family members are not likely to attempt to be at the bedside. A desired outcome for the family is to help as much as possible so they feel they've done all they can. So B, family presence is a positive. We do want them. Everything done possible will help you in the long run. The family might actually be the ones that say, "Oh, I don't want to be in there, or I can't be in there." So you have to kind of talk them into it sometimes, but it does help them in the long run. So on organ donation, just like in adults, every life is valuable for a potential donor. In nursing, we do not approach the family at all. If they approach us, then fine, but we don't talk about it, because there's a conflict of interest between the organ donating company and us. We never want it to seem like we are hurrying them or trying to make them make a decision, or that we are going to get a kickback from this. So we do want to make sure that we call the number. There's an 800 number, and you must have this done within 60 minutes at most hospitals. The call must be made, but whether or not they take the organs or not is a different thought process. So you definitely want to have the family have as much possible time with the baby before this decision is made. If the patient is a viable donor, then the organs are not damaged by disease, trauma, or medications. The protocol for organ donation is followed. So you call the line, they have someone come, they talk to the family. Organ procurement is pretty much commonly done by the transplant surgical team, so they will come. You do not discharge the patient. If you discharge the patient, it's a lot harder for the organ donation team to get into the medical record for us. So you will follow your hospital protocol. There are many protocols that you follow the family member into the OR, and that the patient will die in the operating room. So we keep them on life-sustaining equipment as long as possible until the family members have had a chance to say goodbye. Many times this is going down the OR hall, and everybody gathers to make sure that it is known that this is an organ donor and they are doing the best thing they can for other families. You will get eventually a detailed report back on what organs were used to the hospital. I don't know necessarily that the families necessarily always find that out, but there is a way that they can find out. Again, not all children that die are a candidate for organ donation, so we still need to make the call, and then that's up to them. We do need to make sure that we know the legal guardians obtaining consent, and then also in the withdrawal of care following those protocols for our State Nursing Act. Autopsies can be requested by the family, and we do have do not resuscitate orders and do not do any additional measures on children, just like we do in adults. So in summary, we talked about grief and communication, the family and the patient, and the child's understanding of grief, the end of life in code situations and withdrawing care. We talked about organ donation and the legal considerations with that, and the nurse's role in that, providing that final care.